start this event on how to SGBA, and for those non-Canadians in the audience, that stands for sex, gender-based analysis, which is a CHR, which is equivalent sort of the NIH approach, our funding agency in the US. It's Canadian Institutes for Health Research. And these are some lessons learned by some experts in the field on how they've incorporated gender identity into their research. And before I begin, I want to recognize that we live, work, and play, participate in a community on the unceded and traditional, ancestral and traditional territories of 203 First Nations in Canada, along with 38 Métis chartered communities, each of which possess their own unique traditions and history on the land that where I am right now, where we refer to as British Columbia. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action, the United Nations Declaration on the Rights of Indigenous Peoples, and the BC Declaration on the Rights of Indigenous Peoples Act. In all of our work here at the cluster, we're committed to ensuring Indigenous women's rights to health and safety, and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. And today I'm joining you from Vancouver, which is part of the unceded homelands of the Coast peoples, the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I urge people to put in the chats their own acknowledgements in terms of the lands that they live and work and play on at this moment. And just before I introduce Jill, I just want to thank the members of the working group for SGBA, as they had the brainchild of this event, and the sponsors that made this event possible. So we can have this for free, which is LGVA, the IGH Sex and Trainee Network, and BioTalent. So with that, I'm going to stop sharing my screen, which I will do as soon as I find the stop share button, and then introduce our, I'm very thrilled that Dr. Gillian Einstein agreed to host this event. She is the Wilfred and Joyce Paulson's Chair in Women's Brain Health and Aging, and a professor of psychology at the University of Toronto, and a guest professor of gender and health at the, I'm going to get this pronunciation wrong, but Linköping University in Sweden. She's an adjunct scientist at Women's College Research Institute and the Rotman Research Institute, both in Toronto. She's a board member of the International Gender Medicine Society, chair of the CIHR Institute for Gender and Health Advisory Board, and a founder of, it's a very new group called the Canadian Organization of Gender and Sex Research, otherwise known as COGS. And there'll be a conference actually at the end of May in Montreal. I'm really excited about that. Reach out if you don't know what I'm talking about. There's so much to say about Gillian, so I'm not going to read all of it because otherwise it will take the hour. So
I'll just introduce people now.
Yeah, but thank you so much to Dr. Einstein for agreeing. Over to you.
Thank you. But it's really exciting to be participating in this event, and I thank Lisa very much for thinking of me as the moderator for this event, because she hit all the high points with the people that who she invited, and I know we're in for a real treat. So what I'm going to do is I'm going to introduce everybody first, and then set up the order of their 5-minute talks, and then let them take it away. The purpose of their 5-minute talks is to get you really thinking about things, so that we can have good discussions in the breakout rooms and also an at-large discussion. So our first speaker is Louise Pilote. She's a professor of medicine at McGill University, where she holds the James McGill Chair. She's a practicing general internist and led the McGill Division of General Internal Medicine from 2006 to 2016. As a clinician scientist, she's directed several research initiatives that led to important new insights into the determinants of premature coronary disease. And with support from the Heart and Stroke Foundation of Canada, she leads the Genesis team, which clarified the role of sex and gender in diagnosis, treatment, and outcomes in heart disease, to build capacity in women's heart health research. And it's a paper that many of us cite many times, as well as just talk about in our conversations and our talks. She recently launched the Going Forward Consortium on Data Science Personalized Medicine project funded by CIHR and the European GenderNet Plus initiative. with 30 million patients with chronic disease across Canada and Europe, and she'll be analyzing it using a sex and gender lens, SGBA, and probably plus, to more precisely predict their risk of clinical and patient relevant outcomes. It's really terrific, exciting project. The fun fact about Louise is that she builds a skating rink every winter, and she has a Twitter handle @PiloteDoctor. So actually, given that, I think, Louise, why don't you speak, and then I'll introduce our next speaker then.
Hi, everyone. I will start with sharing my screen. Yeah. Okay. All right. So it's hard to talk about this in 5 minutes. I have quite a few slides, but I just want to share with you how we learn to measure gender and incorporate gender in cardiovascular research. I'm going to present a little bit what I presented before, but with a little bit more of an insight into the difficulties. So in cardiovascular research, we have noticed that there's been a decline in the death related to cardiovascular disease. So that's great progress. But if we looked at age, we found that patients less than 55, the progress was much less. It's the top left corner here for females than males. And we were wondering why. And there was some data that BC that showed, if anything, there was a rate of the AMI that was increasing in the young, especially in young females. So that led to a study called the Genesis Practice Study that included 1,500 patients who had an acute coronary syndrome, heart attack, across 24 centers in Canada. And then what we found is that the prevalence of the traditional risk factor was quite high in these young females. In red, you can see the various risk factors, in fact, higher than in men. And we also found that the psychosocial factors, stress, living with child, low stress management, and low social support, being unemployed, also was quite high and higher in females and males. So we wanted to, at the time, we were thinking a little at the time, what is sex, what is gender? And we got some guidance from Joy Johnson at the time. And we put together a conceptual model of how we thought, the sex differences were explained through some sex-specific factors and then psychosocial factors. This is how we kind of started to think about the fact that some of the psychosocial factors are in fact gendered. And then we had to figure out, if we're going to try to explain this in a multivariate analysis, how are we going to measure gender? So that's what led us in our questionnaire to derive some questions that were related to the gender constructs that the CIHR and your group, in fact, Lauren Greaves and all, had really identified, and it was really helpful in identifying questions in that young population that would really help us delineate what is, the sex differences. I remember someone saying, why are you looking at sex differences? We know they exist. I said, I want to know why they exist. And then the hypothesis is that it was not only biology, but certainly the social position of people in society. So just quickly, we had questions on gender roles. We had questions on gender identity at the time, and we had gender relations questions. Just, I'm showing that quickly. And then we had questions on institutionalized gender, which people think socioeconomic status is an intersecting variable, but it is really in our society an institutionalized gender variable. So then we said all these questions, we have to reduce them and really identify the unique contribution in the data. So we did a data reduction method, the PCA, and then we identified, some factor loading, some components. And this gave us a smaller list of factors. And then with these estimates, then we created the famous score. And we found, the reason for having this score was, again, reducing and really, dissociating the effect of sex and gender. So, but it really made us understand that, gender is a continuum, it's not a binary thing. And with that score, we found that, for example, if we look at the distribution in males and females, we arrive with this kind of graph that people refer to, and it tells us that, you know, with all these questions that we posed, that this kind of gender-related questions, we found that, you know, so for males and females, it's kind of on a continuum. There's certainly more like for males, some questions that are more related to being a male in society, but, you know, it's not like on one line. So that was, and then the next question then was that affecting, you know, risk factors with heart disease? Is it an effect on disease? So again, you know, is it biology and is it, you know, gender? So just to show an example with hypertension, which is one of the most important risk factors for heart disease, which is a big problem for women and is ignored compared to the other risk factors, I find. We found that, for example, the gender score, there was a per unit score, double the risk of hypertension. For female sex, yes, also in this young population, increased risk. But when we did a multivariate analysis, it was really the gender that stayed, and then the sex itself, you know, disappeared. So highlighting that in looking at sex differences, you know, if you take away being female or male, the gender-related factors, you know, the psychosocial factors are very important in determining the risk of developing risk factors for heart disease. So that gives us an idea of where we need to target our interventions. And then we looked at other more like called hard outcome in terms of MACE and the risk of having a recurrent ACS. And in fact, we did find that independent of sex, if you were of a gender that was more traditionally ascribed to female roles in society, your risk was actually higher to have another event. So now, you know, the reactions to the score, why a score? I remember going to the USSD and it was like, why do you do a score? Why do you put gender in a score? What is this? And then I can tell you that I've struggled with that, and I have realized that the Framingham risk score, nobody ever, you know, said that, is it, why do you need a score? You need to know what is hypertension, what is diabetes, why a score? We use a score all the time because we really want to know, again, the construct of psychosocial determinants, you know, what is its importance in relationship to the biology. I am questioning now, is gender same as social determinants of health? How to integrate gender role in the clinical setting? When I work in the ER, how am I going to include gender? How am I going to consider that? And how is gender roles and relations defined in various cultures that brought the going forward? And how does the effect vary across diseases and also across cultures? So just to finalize, you know, in terms of answering the questions, the going forward, we derive a methodology. We work further into the methodology to measure gender in retrospective study, identifying gender-related variables, defining the outcome, build a list of gender-related factors, harmonize the data, and then do the analysis. And then we also published a paper, again, looking at prospectively, how do you measure gender? A bit like saying how we did it with Genesis Praxis. But again, identifying individual level variable, interpersonal level variables, and societal level variables. And then based on your research question, you don't have to measure everything, because people are kind of always a little bit concerned about, do I have to measure gender, everything? It's really based hypothesis generating. If marital status is important, you know, to look at the association between, you know, mortality and something else, you know, then that's what you will focus on. So that's what kind of we're saying in this paper in the Journal of Clinical Epidemiology.
That's great. Louise, that's great. Thank you. You did a great job. My alarm just went off.
So that's, I just wanted to thank, you know, the Going Forward consortium.
Yeah, that's fantastic. And I think, you know, your work really does show, first of all, the possibility of what you can learn when you do give us a number, a score to gender, and also how gender becomes biological as well. So I thank you for that. Okay, our next speaker is Dr. Greta Bauer. And Dr. Bauer is a professor in the Department of Epidemiology and Biostatistics in the Schulich School of Medicine and Dentistry and the CIHR Sex and Gender Science Chair. Dr. Bauer came to Western after completing her PhD at the University of Minnesota School of Public Health and brings a strong public health focus to her work. Her primary research interests are in social marginalization and health, particularly as related to sexual and gender minority communities, and in quantitative research methodology for studying communities that experience marginalization. Now, I know that Dr. Bauer, there are a lot of fun things about her, but she doesn't have a fun fact. And she's directed us to the Twitter handle for her department at Western, which I completely sympathize with and understand. So please, Greta, take it away.
Okay. Yeah, I was not feeling fun when I was asked for a fun fact. And I don't have one for you now, but hopefully I have some fun things to talk about in this presentation because I'm going to continue on the topic of measurement. And since we're talking lessons learned, I decided to just put it's a spoiler alert here. I'm just putting the conclusion in the title here. Cisnormativity leads to bad research on cisgender people. So we'll start there because you may know I've done a lot of trans health research and non-binary health research. And we talk a lot about cisnormativity in that, but we don't talk about what it means outside of that. So cisnormativity is the rarely voiced assumption that all dimensions of sex and of gender are concordant within individuals and consistent over the life course. And what this means from a research perspective is if we know one thing about somebody, we assume we know many, many other things about them with regard to their sex and gender and what that's looked like over life. So if we know that somebody identifies as a man, for example, the gender identity, we often assume that they're XY chromosomally, that they've never been pregnant, that they're not dealing with internalized gender stigma related to being female or related to being trans or non-binary, and that other people perceive them as a man, that all of these things kind of go together. And furthermore, that they grew up as a boy and they're going to grow old as a man, and that's consistent over the life course. So this is cisnormativity, and it impacts trans people really heavily, but it also impacts cisgender people. For example, when a woman is assumed to be able to get pregnant when she's young or to have a uterus, and we see that the gendering of that as well with women who feel like they're not really women if they can't be pregnant or things like that. So it gets tied together for cisgender people as well. And for us as researchers, certainly with secondary data analysis, we're often stuck with undifferentiated measures of sex, gender, and administrative databases where it's not necessarily clear what dimension is being captured. Or even, if we're using old BRFSS data from the US, researcher perceives sex, gender based on participants' voice or other things like that. And so, historically, we've just accepted those databases and said, these are men, these are women, and then we kind of make assumptions from there. So I want to present you with an example of one time that did not work very well and make a little proposal about one big thing or key thing that we could do to do a better job at this. So my example involves an undifferentiated survey measure of sex gender as a proxy measure for organ-specific sex. So there's a cisnormative assumption that those go together, which really prevented this research methodology issue from being solved over a decades-long period. And our story actually starts in the late 1970s when researchers first noted the fact that in doing sexual and reproductive cancer research, they often really wanted data on organs, on who has a cervix or who has a uterus, and they were stuck with, is this a man or a woman in a database? And the first real analysis of that took place in the late 90s here with Canadian data, where researchers had concluded that unmet need for pap smears increased with age. And then later on, after adjusting for hysterectomy status, changed their conclusion. So this is the late 90s from a problem identified in the 1970s. And then we continue on to the mid to late 2010s before we finally see a body of research on hysterectomy-corrected sexual and reproductive cancers. And what that identified was not only had risk been misestimated, but age trends had been misestimated, racial disparities had been misestimated, and there's been a whole ongoing process of revising that entire literature over decades because these differences were not insubstantial. There were sometimes, 40% difference in what had been estimated and what was correctly estimated. And so I had to ask, if it was cisnormative assumptions that kept researchers from really making that distinction, or from, even when we know that there's a high rate of hysterectomy, we know that that's common. We know that we should estimate things in people at risk in epidemiology. Why did people assume that this was still a reasonable proxy measure? So I have to ask, what would happen if we really treated sex and gender measurement just as we treat measurement of other variables? We took the same tools that we have as researchers, and I know this is a group that's doing some of that. But even with regard to these very basic measures, And I'm not expecting you to take all of this in, but at the top here, what we have is basically a 2x2 table in my attempt to approximate using existing data what we could learn about database encoded sex gender as a proxy for uterine status if we were just to take existing knowledge and try to estimate who goes in which cell. And I did this across different intersections of Black and white race using US data in different age groups. And what I found, and this is just kind of proof of concept at this point, is that you can use existing data, or we could do studies to actually evaluate this just as we do other measures, in this case with sensitivity and specificity. And what I've learned from this is that sensitivity is generally pretty good overall. That's the proportion of people with uteri who are captured as database encoded women. But the specificity is not only less good, its performance as a proxy measure actually varies in terms of specificity by age, by racial group intersections. And in fact, if I had better US data, I think we would find that it also varies by geographic area, because racial differences in hysterectomy vary by geographic area in the US as well.
Good, and maybe one more minute?
Yeah.
Okay.
We're good. What this means is that the measurement and the performance of that can actually drive these observations of trends or shape the magnitude or direction of trends, as well as racial disparities. So that's why my case study here and the lessons are that we've had this ongoing issue with cisnormativity leading to, I think, not taking seriously how we evaluate sex and gender measures. And ultimately, if we did so, we could produce results that are both more valid, more interpretable, and more likely to inform our understanding of causation.
Thank you so much, Greta. That's really awesome. I mean, it really does bring to the fore how we need to question our assumptions as we design our studies. We can't just assume we can do our studies in the same way that everybody else has. Our next speaker is Dr. Robert Paul Euster. And Dr. Euster is a neuroscientist focused on stress biology, mental health, coping, and resilience, with a focus on sex and gender perspectives. In particular, Dr. Euster's research includes LGBTQ+ people and how stigma exposure across the lifetime development. Dr. Euster holds a CIHR Sex and Gender Science Chair of LGBTQ2S Wellness and Resilience. And our fun fact about Rob is that he once dreamed of becoming an actor because he loves impersonating people. And his Twitter handle is @Rob_Paul_Euster. So
thanks, Gillian.
Thank you.
Can everyone see my slides?
Yeah.
So thank you so much for the invitation. I'm a stress researcher. My mentors were Sonia Lupien and Jens Prusner. And I came at sex and gender from a perspective of a stress researcher. And one take-home message that I want to give in this presentation is that it's important to triangulate methods. So taking environmental perspectives, psychological perspectives, and biological perspectives when studying stress and sex and gender. One way that we look at stress is by looking at diurnal cortisol, so variation throughout the day, as well as stressing people out. And here it's interesting, men in general have higher levels of cortisol in response to performance stressors, while there's evidence to suggest that women are more sensitive to social rejection paradigms. Allostatic load is a model that goes beyond looking at stress hormones. It looks at central nervous system functioning, metabolism, immune functioning, cardiovascular functioning, and it's a metric of chronic stress in synergy with unhealthy behaviors. You can think of it as the straw that breaks the camel's back, and it can be indexed with an array of different biomarkers that are related in some way to stress. And in reviewing this literature, I became very interested in sex as a variable, but I want to really emphasize that so many of these variables are interconnected. So you could imagine health behaviors as being gendered. You can think about social context as gendered. And all of this is going to relate to allostatic load, and allostatic load is predictive of numerous stress-related conditions. And so much of my career has been dedicated to identifying sex and gender factors in relation to allostatic load. And this presentation will go in each of these rather quickly because I don't have too much time. So first, for birth-assigned sex and sex hormones, I was very interested in identifying whether adjusting for sex hormones was important in looking at cortisol. And Here, what you normally see, people are exposed to a stressor, they respond, men are showing higher levels of cortisol, no differences for diurnal cortisol. But when we actually adjust for testosterone, estrogen, and progesterone, we lose this classic stress reactivity difference between women and men, and we unmask a diurnal cortisol difference. And this is actually driven by women that have children at home, as well as higher levels of testosterone in older women. So it's an interesting finding and forced us to think about sex hormones as something important in this literature. Now, for sex differences in allostatic load, of the studies that actually measure it and don't treat it like a covariate, in general, men seem to have higher allostatic load than women. But women show a lot more sociocultural variation. So women benefit more from being in religious services, and their social supports are different from men. So this got me thinking about gender roles as an important variable to look at. And this was based on BEM's stereotypical personality trait questionnaire and the idea that people who show high masculinity and high femininity would be more physiologically healthy. And we actually looked at this with allostatic load from an array of 20 different biomarkers. But here's the problem. For these 20 different biomarkers, there were 10 of them that were different between men and women. And that's something that's actually never looked at in the literature. So we created a formulation without regard for sex, so all-inclusive, and sex-specific. And what we found was that without regard for sex, men show higher allostatic load than women. But for a sex-specific formulation, we unmask a sex by gender role interaction, where androgynous men, as Ben proposed, show lower allostatic load than undifferentiated men. But I'd like to point out no differences among women, which was perplexing. And so we wanted to go one step further to identify occupational gender roles. So based on stereotypes of people's occupations, we wanted to see how this would be related to allostatic load, in addition to individual gender roles. And so individual gender roles are all related to mental health outcomes and allostatic load, but occupational gender roles were really related to a lot of workplace stressors. So that's something that we're going to explore in the future by looking at the mismatch between individual gender roles and occupational gender roles. And a lot of Louise Pilote's work has been extremely inspirational in thinking about institutionalized gender and socio-demographic factors related to gender. Here's one study with Bianca D'Antonio that actually shows, looking at occupational status, men have higher allostatic load with higher social economic status. Well, we see the complete reverse among women. This is a really interesting finding that was actually driven by younger men. So again, social economics is an important consideration when thinking about sex and gender. Now for sexual orientation, this was some of my work during my PhD, where we looked at sexual orientation with 3 different approaches. And what we found was for stress reactivity, lesbian and bisexual women actually showed higher levels of cortisol after a stressor compared to heterosexual women. And then for gay and bisexual men, no differences compared to heterosexual men. When we looked at diurnal cortisol, we didn't find any differences based on sexual orientation, but we had information on whether people had come out of the closet. And for those that had, they had lower levels of cortisol in the morning compared to those that had not completely come out to family and friends. Now for allostatic load, we had 20 different biomarkers. This is a very expensive study. Sonia wasn't too happy, but so be it. We found gay and bisexual men actually had lower allostatic load than heterosexual men. And this was driven by lower triglycerides, lower body mass index, and lower inflammation. We didn't find differences based on coming out, but secondary analysis found that those that engage in less avoidance coping actually had lower allostatic load.
Maybe one more minute, Rob.
Yeah, that sounds good. We replicated this finding with 14,000 Americans and found again that gay men had lower allostatic load, but now bisexual men had higher allostatic load. No differences were found in women. Moving forward, we're going to be looking at state level information as a way to index structural stigma for sexual minorities. But this approach could also be used to look at institutionalized gender in different states and different geographic areas. Now, just to conclude with some data on gender identity, this is work from Zachary Dubois, looking at transitioning transgender men. And I just want to point out that this was a study that used items very similar to Greta's multidimensional measure. I'd also like to just point out that there's a lot of variation in terms of how people will identify based on open-ended responses. And what we found was that those with more transgender identity stress, more stress with coming out, and more stress with public restrooms had higher levels of diurnal cortisol. Lastly, we have one study under review right now where we look at allostatic load, and we find that people living in less progressive geopolitical areas in the US had higher allostatic load based on these different parameters. So moving forward, we're very interested in minority status in relation to stigma and really adding biomarkers as a complement to a lot of the work in public health and in psychology and taking perspectives of resilience. So with that, it takes a gay village and a lot of collaborators to do this work. And I'd just like to thank my students and our funders. Thank you.
Thanks so much, Rob. That was great. Okay, our next speaker is Dr. Sophia Ahmed. And Dr. Ahmed is a nephrologist and clinician scientist with a focus on sex differences in human cardiovascular and kidney physiology and outcomes. Dr. Ahmed is a professor in the Department of Medicine, Cummings School of Medicine at the University of Calgary, and she's the vice chair of research for the Department of Medicine. And her fun fact is that her first job was at A&W. So her Twitter handle is @Sophia Ahmed MD. Sophia, please take it away.
Excellent. So thank you so much for that kind introduction. And I'm really honored to be here today. So I'm speaking to you today from the traditional and present day territories of the Treaty 7 people of Southern Alberta. And Calgary is also home to Métis Nation of Alberta Region 3. Okay, so, oh, I can't go forward. This is it. There we go. So as Gillian said, I'm a kidney specialist. And so I thought I'd talk to you a little bit today about how sex and gender impact kidney health. So first, you probably are wondering, well, how do I even know what someone's kidneys are doing, if they're actually, are they working or not? So it's a blood test that probably many people in the audience have had. It's called creatinine, and creatinine is made by our muscles. The creatinine secretes into our bloodstream, circulates around the body, filtered by the kidneys, and then you pee it out. If your kidneys are not working as well, the creatinine starts to build up in the body. And that's how your healthcare provider knows that there's something going on with your kidney function. But I told you that creatinine is made by your muscles, which is influenced by a person's sex, potentially their gender, certainly their age. And so what we do is we have an equation called the CKD-EPI equation, and we punch in what the creatinine is, so what the result is from that blood test, what the person's age is, what their gender is, and as you can see, the options are male or female. And basically it gives us a measure of kidney function, which we call GFR, but you can kind of think of it as a percentage of kidney function. Now you're probably saying, okay, Sophia, you just said gender, and as the other presenters have so eloquently pointed out, there are differences between sex, which is biology, and gender, which is identity, roles, relations, institutionalized gender. So which is it that as a clinician, one would put into this equation? And I would answer, I have no idea, because this globally used equation was derived from multiple studies from around the world, different populations. It's not clear what was inputted and how it was collected, whether it was sex, whether it was gender, and who collected it. So I want to highlight that. Let's imagine someone has a creatinine of 300, which is quite an elevated creatinine, meaning there's pretty advanced kidney disease. We put in that they're male, they're 31 years old, and we get that they have a GFR or percentage of 24. Now, if the only thing we change is we actually decide to put in female, we see that their GFR goes down to 18. So just by changing, and it's unclear, as I said, the gender, and I assume that means gender identity or sex of the person, there's a 6-point difference in terms of kidney function. And this has real world implications. So, this will, as a clinician, I will alter this person's drug dose. So this could be their antibiotic, their chemotherapy dose, whether they're listed for kidney transplant or not, or even eligible, whether they get referred to someone like me, a kidney specialist, or whether they initiate dialysis or not. So this has real world implications, which what we input into that equation. So this is Dr. Cam Whitley, who is a professor of sociology, I'm forgetting, but in the US. And Dr. Whitley presented to the hospital with very advanced, very elevated creatinine and very advanced kidney disease. And his healthcare providers treated him and he got sicker and sicker. And then his case was written up by the BBC and basically highlighting why transgender people are ignored by modern medicine. So all of his providers had assumed just by looking at Dr. Whitley that he was cisgender. He was a biological male whose gender identity was a man. And it didn't work out very well for him. Fortunately, he has now been treated appropriately. And he actually participated in his own write-up of his case report. He's the first author on this. So if you want to know more, you can read it. So this just is to highlight how important it is that we accurately capture sex and gender identity. I'm going to focus on gender identity for this, the next 2 minutes, I promise, Jill. So if all of us would have filled out the census last year, this is new in Canada where they recorded a person's sex at birth and gender. These were the questions that you would have seen. So question one, so you don't ask in your research, what sex are you? Because that's very confusing to people. So you say, what sex were you assigned at birth? What does it say on your original birth certificate? And the two options that were available on the census were male and female. But we in our lab have added intersex, and I prefer not to say, and that's really important that you include that. The second question, as you can see here, is which best describes your current identity. We can talk about the use of the words male and female. The good news is that they did say, please specify this person's gender, because it's important to allow people to self-identify and you never want to put other. We can talk about that in our breakout group. So this is just an example of one student in our lab, Danica Chang, who's done a survey, and these are the gender identity options that she has listed. I just want to highlight that they're listed in alphabetical order because you don't want to imply a hierarchy in terms of choices. And again, it's important to have, I prefer to self-identify. Also, I prefer not to say, which it looks like I've cut that off. Sorry about that. In JAMA a few years ago, Dr. Clayton, who's the director of the Office for Research in Women's Health at the NIH, and Dr. Tannenbaum, who's the scientific director for IGH here at CIHR, published this. And just to highlight that when you report your research, you want to report it by both sex assigned at birth as well as gender. They only have two options here, but also depending on what your population is. It's also important to say how you collected the data, going back to that calculation of
maybe 1 more minute, Sophia.
Absolutely, I have 30 seconds actually.
Okay.
So you need to put that in your methodology. And the last slide I have is it's important to include the community. So that great list of gender identities that Danica has, we partnered with our community members, Skipping Stone, which is an organization that supports the trans community, because at the end of the day, we want our research to help the people that, everyone. So anyway, I'll end there. Sorry. Thank you.
Thank you so much. I mean, it's really been the breadth of the approaches and the concerns in these talks, even getting to everyday stress of sexual minorities, as well as how what does that term in the questionnaire, what's your gender, what does it really mean, what are they trying to get at, and how do you actually specify it? These are really, really great and important things to know about. So we're going to have a kind of roundtable discussion now. I'm not sure, Catherine, who's going to call on people? Should I be calling on people, or?
You can go ahead and just facilitate the conversation. And if you want to point it at a certain speaker, then go for it.
Okay, so would you please raise your hands instead of putting things in the chat, and then I will try to browse all 4 pages here. Just to get the ball rolling, after hearing everyone's presentations, just was there anything that stuck out to you about the way all the speakers or just your colleagues in general incorporate gender into their research? So ready to take any comments on that or any particular questions?
Well, I wonder if the four speakers just want to talk about like maybe even each other's works, but like I was just struck by how different findings you can get when you dig a little deeper into your data. And I mean, Louise, was like very masterful on how you created that composite score, but each one of you presented a problem in your data that when you really did a deep consideration of sex and gender variables, you came out with richer data, which I think is sort of the point that Greta was sort of making. Don't assume things is also the other point I think she was making. But I'm just wondering if they have any thoughts.
Because if I may say that, I told in the reactions that I have had, and I'm still struggling with that, the application to the patient population that I deal with. So I was really struck by Sophia's presentation. I use this GFR calculation all the time. And then the slide that says that, it's different between males and females, and it has implication on the drug dose, on the, is someone going to go for dialysis? I mean, this to me, it's so important. So it shows it's not so much gender, but definitely. So all these calculations that we have, that first of all, many of those calculations don't take into account the sex of the person, but some of them do, and they have major implications. So that for me was really eye-opening.
Any other thoughts?
Well, I just found, not being a kidney expert, of course, I found myself just asking questions about what is it about sex? Because if we look at that as something multidimensional, it's sex assigned at birth is an event and most often corresponds with chromosomal sex, but there's just so many hormonal factors. And I think that's something that Robert Paul showed as well. And it's something certainly, with trans people that changes over the life course, but it changes with cisgender people too. And I always just wonder what we're missing by not really looking at variation in hormones as deeply as we could. Because even when we're doing differences between men and women, of course, postmenopausal women have a very different hormonal milieu than women of reproductive ages, even if we're just looking at those averages. And then there's so much variation between people in those as well. So I was just bringing up all kinds of questions for me about, I wonder what it is exactly, that might be most important there.
I'd like to just add to that. Congratulations on your Meet the Methods, where you really beautifully show out intersectionality. And I think each identity, each intersection creates its own variation. And just thinking about what constitutes biological sex, there's so many continuums. And I think trying to get people to really see that both at the biological and the sociocultural gender level is really critical. That we're not doing this to classify or categorize people. We're doing this to really allow the richness of our data to really speak for itself.
We actually have a hand raised from a participant, Morgan Sterling. Morgan?
Hi, can you hear me?
Yep.
My question is for Dr. Ahmed. And I'm just wondering if maybe you can speak to some of the experience, and this can be for anybody really, in terms of changing fields in medical records. I've done a little bit about this, and I've come into like a number of challenges, like working with the vendors and the administrators around being able to change fields in electronic records. It costs a lot to make those changes, the impact that it has on the providers in terms of practice changes, and then also how that information then, filters into some of the other data sets or administrative data, because there isn't often a corresponding data field for that field to kind of go into. So I'm just wondering if you can kind of speak, or if anybody can kind of speak to, some successes around being able to successfully change that, so we have access to that information.
So I can start. So Morgan, if I'm understanding your question correctly, is how did the gender marker, or who knows if it's sex or gender identity marker in the clinical records? Is that what you were asking, like how to access that, how to change that, if that's appropriate? Is that?
It's more trying to like deal with the challenges in changing the electronic record to make gender a field. And most of the times, in my experience, I'm in Manitoba. We don't have gender as a field in our electronic medical records, and there's significant limitations in terms of making that information available in electronic records. I'm just wondering if you.
No, I can. That's a great question. I would be really interested to hear what others have to say on this. I can tell you that at least in Alberta, we only have one marker, and whether it says M or F, whether that's attributed to someone's sex or someone's gender. At least I think it's self-identified, that people will write it in. There is the ability to change it, whether that costs money or how to go about that, I'm not actually sure. There are studies that have looked at including sex and gender identity, some small studies in the clinical record. And there's actually been some mixed results in terms of outcomes, because in some cases, one would hope it would result in better care of that person. But in some cases, it has actually backfired and resulted in discrimination to that person. So I think it's something that needs to be studied, because at the end of the day, you want to have accurate information in the chart, and you want to make sure that that information is going to improve that person's care. So I don't know the right answer. I'd like to open that up to other people. Greta, I know you've worked with a lot of big data sets. So do you have any thoughts on this?
I think medical records are a little different. The only medical records I've worked with are of trans youth who are coming in for clinical care. I mean, I know people have really different thoughts about what they want recorded in their medical record for some of the reasons that you mentioned, as to whether they're automatically outed to people or they're not. And some of my colleagues, like Maddie Deutsch, Dr. Deutsch in the United States, has written a couple of papers, some in conjunction with WPATH, on practices for medical records that people can look at if they haven't seen those. And some are suggesting that there be a range of different fields, because sex also isn't one thing. There's sex assigned at birth, but then of course people have had different surgeries, and that really impacts what kind of screening they need, what kind of medical care they need. And then of course hormonal levels may impact things as well. And then there's always the question about what of that is most relevant for the issue you're discussing too, with that, but any kind of test that involves different reference ranges for males and females, as to how that should be put through. So there are people more knowledgeable than I on medical records who are working on this now. So that gives me good hope, and running into some problems with those systems related to, mostly institutional kind of problems around database structure and difficulty in changing things, but also issues in terms of disagreement as to what the best way to encode that is. I think the one thing everybody agrees on at this point is that there should be a field for the name somebody wants to be called within medical records, and that's not just for trans people, it's for people to be treated respectfully. But around sex, it's moving forward without a clear agreement by people who, as I said, are more knowledgeable than I am on that area.
Yeah, so
if I may add, I'm sorry.
I just want to let Sophia know that there are comments for her in the chat if you have time to take a look at them. Sorry, Louise.
I've worked extensively with medical records, like administrative databases, and unfortunately, we don't have, we have the sex, the traditional sex, male, female, nothing else. And even for gender-related factors, to be able to measure that with the Canadian, the supposedly rich administrative databases, there's really not much to have there. There's a kind of a socioeconomic scale. It's called the Pampalus or anyways, that is available, but that's pretty much it. And then there's the Chi-High. And I think, Morgan, you alerted me to the importance of letting, the people who hold Chi-High to work on these variables, not only, the gender variables and, identity variables, but also, other intersectional variables like, ethnicity. It's not possible to get ethnicity, in the Chi-High database, socioeconomic status. So, I think it's important for one to push this area of research to make sure that, the medical records incorporate, some of these novel variables. Very important. It's something we have to do.
I just wanted to, I put an article in the chat from CMAJ and from 2019. It's from St. Michael's Hospital, which in Toronto, which probably has the largest family practice in all of Canada. And basically they asked people, what's your gender identity as well as sexual orientation, and matched it to what was in the chart. And while like the majority of the time what was in the chart matched with person's gender identity, and this is what like their family doctor had, it didn't always, which is really shocking when you think about that your family doc would not know what your identity was. But anyway, I throw that in there.
If I could just say one of the things that struck me about your talks is the issue that I think a lot of us think about all the time, not so much with respect to gender identity, although it may play a role there, but with the fact that when you're talking about institutionalized gender, you're talking about a social phenomenon that if you're not working in a database, but you're just facing a person, you have this complicating issue of different levels of knowledge. So it's like if you want to do a mean and a standard deviation, that's one thing. But if you want to find out how somebody feels about their condition or their identification, that's a whole different set of methods. And how you bring these methods together, I think, is something that's quite interesting in terms of how we do science. And I think that studying gender along with sex raises that question. And what I found interesting about each of these talks is that each talk is not a solution exactly, but is a way of dealing with that in a very specific domain. So I found that fascinating, and I'm sure there are others. I mean, we take our own approach, which I won't go into now, but I think that's one of the things that fascinates me the most about bringing sex and gender together. It's like, how do you take these very different levels of knowledge and analyze them together? So I see that Zoe Citas has a question.
Hello, hi, I'm dialing in from Sydney, Australia. I just have a question regarding the Canadian census. So you mentioned, and thank you everyone for your amazing talks, they were so great. With the Canadian census, what was intersex and gender variances and gender identity included in the national database? Because I'm talking from the Australian perspective, where we had some questions that included gender variance, which were rather problematic, but they were auto categorized into male or female anyway. Does that make sense?
The questions, so welcome to Canada. The questions that I listed in there, that's pulled directly from the web, which I'll put actually in the chat, the census, that's what was asked. They haven't, as far as I'm aware, reported the results as yet, but I don't know if anybody else knows anything different.
The new standard came in April of 2018, and they started to use it in the surveys before the census came around. So the first large survey it was used in was the survey of safety in public and private spaces. So that those data have been out for a while, and that's going to be used standard across the surveys. They do have the write-in, and they do group people, and so they feel quite comfortable doing that. I think that's what you're talking about, right? That people could write in other things, but then they would classify them. is one of the reasons I, as a researcher, like closed-ended questions, even if I had to say to participants, if you had to choose one of these for the purposes of a survey, which would it be? Because as somebody behind the scenes reclassifying people into groups, I think that's problematic too, because you're going to put them in groups that are not the one they would have chosen if it was forced choice. So do they do that? They do that. For the previous census, they had told people to just choose what was best, and if they skipped it, it would be no problem as long as they wrote in later what their gender was. And then Statistics Canada did a full analysis of all those write-ins, along with consultation with community in English and French to come up with the new standard. But they're still classifying people for some measures. And I think there's a rationale for some of that in terms of needing to track trends over time and wanting to have something more comparable, but it's not really clear how that classification happens behind the scenes. I hope that addressed that part of your question.
Yes, thank you so much.
There's a great question in the chat that I'm just particularly interested in myself, which is about hormonal conditions such as PCOS falling under intersex, and how would that be included? And actually, PCOS is a really interesting example of this, where if you're not a totally identifying cisgendered woman, the whole, it seems like the practice guidelines around PCOS feminize you, because so much about what physicians are interested in is whether or not you'll be able to bear children, losing weight to cut down on the likelihood of diabetes, and you know, that sort of thing. And we've been interviewing persons with PCOS who are beginning to see themselves as intersex, which I think is really fascinating, and a fascinating move among some of the people with PCOS. So I just wanted to bring that up and mention that, because that's such an interesting question.
Maybe Jill, just say what PCOS is.
Oh, sorry, polycystic ovarian syndrome. So it's often been, I mean, like Sophia will be able to say more about this than I possibly can, but it's often been treated as a problem of really high testosterone. But actually, the women with PCOS also have insulin production problems as well. And it's very multifactorial endocrinological problem. But we began to wonder whether PCOS might not begin to be seen as something beneficial to people who were gender questioning or more gender fluid. And that's why we started talking to them. And I'm not going to burst I don't want to give away the punchline, but it's really very interesting area.
So I'm just wondering, before we go to the breakout rooms, like if people are feeling more empowered, or, oh my gosh, this is so complicated, we should have put a poll in to that thing, because I'm just, sometimes, even my lab, we will look at some databases, and we can't always ask the questions that we can't answer the questions we originally went into the database for, because the information's not there. So one fix would be, okay, let's make sure we have some standardized questions that we put in. But then listening to some of the talks, I'm thinking, what questions? I mean, we got to start somewhere and get the questions in there. But I'm just
yeah, you gave me a whole series of questions to ask.
Maybe I can answer that a little bit, because we were asking ourselves that, what question to ask. So, we had the structure of, roles, relations, and all that. And then we had as a criteria that, these questions would have had evidence in the literature to have, a difference between males and females in terms of the strength of their association or their prevalence, so because what does it mean to call something gendered, And then, we kind of had at the time to have a definition to say, okay, it's a factor that differs in terms of its prevalence and also the magnitude of its impact between the two sexes, or, at the time. So, we had this, and then we wanted to have at least like a relative risk or an odds ratio of 1.5. And then, we had to use questions that we were not going to validate, so they had to be questions, that pertain to roles, relations, and identity and institutionalized gender that the questionnaires had been validated before. Because then, it becomes endless. And then as we thought about it more, we said, it has, as I said in my talk, to move forward, you have to have a hypothesis about how gender may influence what you want to look at. And then you narrow down, that particular aspect of gender that may be, pertinent. Otherwise, it is daunting. So, it has to be a bit based on the literature and the hypothesis generating as to which is the most important gender aspect that may have an importance in whatever you're studying.
But gender norms are shifting all the time. It might actually, what questions you ask might really depend on the age of the population you're studying, for example. Or maybe just like culture is incredibly important here, but they're pretty fluid.
Also very culturally sensitive to like where you live in the world.
Yeah.
By definition, everyone on this call probably by the fact that we're here in some parts of the world might be considered very masculine because it's work outside the home, for example. So, which I don't think in other settings, it would be considered more androgynous. So anyway, that would be my take.
Yeah, I mean, actually, in setting up not in setting up, but now in thinking about the database for the Canadian Consortium on Neurodegeneration and Aging, people are beginning to ask, should we be asking our participants their sex at birth? And then what is their gender identification? And I think it would be terrific, but I think for some of the 80-year-old people in the study, I'm wondering how they will understand what is your sex at birth and what is your gender ID. I don't know, Greta, you must have thought about this quite a bit.
We did a paper on that. There's a paper on trans-inclusive sex gender measures for population health studies, and it's not, the kind of recommended questions at the end are a little different than what I would ask now too. But the sections on all the different issues that came up are really good, I think, in terms of highlighting those. And the one thing that we found is that it was really interesting, actually, the interviews with like the old, straight, cisgender, white, male farmer from somewhere on the prairies, they did fine. They understood the question. Sometimes people thought it was redundant.
Oh,
They thought,
interesting.
you already asked this, but they understood it and they answered it correctly.
That's
sometimes
great.
they laughed and they're like, it was simpler in my day. And, in the interview, we did cognitive interviews with participants. So we really got at how they thought about the questions and how they answered them. And so it really wasn't a problem in terms of confusion.
That's
and we
great.
had a lot of people who, were coming from different linguistic backgrounds and things like that as well.
Oh, that's really great. So I see that Tiffany Greco has a question or a comment.
Hi, so I'm Tiffany Greco. I'm here at UCLA. Thank you for organizing this. It's been wonderful to listen to everyone. I had a question more so as it pertains to ICU patients that come in and, are non-responsive, and identification of those patients, obviously potentially looking at their genitals and just assuming their sex based on that, and treatment based on sex. And then for folks that may be on hormone therapy, whether that's birth control or whatever they're taking for themselves, and having that abruptly stopped while someone's potentially in a comatose state, how, as they come out of that in their recovery mode, how that affects self-identification, getting them back on appropriate treatment. As I work specifically with traumatic brain injury, so how removal of hormones that somebody was on can affect their trajectory of recovery after injury. Rachel McCusick had a study looking more to do with athletes that were on testosterone. And if you abruptly stop the testosterone after injury, they had a worse outcome. Whereas if you continued that testosterone therapy throughout injury and recovery, they were fine. So I know it's a lot of questions in one little block, but what are the kind of things being done to address that within emergency and ICU situations? Because that's what we deal with a lot here.
That's a really good question.
I can answer. I don't know if Louise has comments too from a clinical person or anyone else. So you're absolutely right. If someone was in the ICU and not responsive, I suspect people, well, they would, if they could, look at the chart and see what the marker is there. And then you're absolutely right. Someone's genitalia would be seen because they would put in a Foley catheter, which is to collect the urine. So just because if they're sick enough to be in the ICU, that would happen. In terms of starting or stopping hormones, that's a really good question. So in the case of people who are taking gender affirming hormone therapy for feminizing or masculinizing as part of the trans community, if it was prescribed, meaning it was on the medical record, it would continue, generally speaking. And many people, part of the trans community, get their hormones, I use the word black market, that's not, but just it's under the table or it's non-prescribed. So if you didn't know about it, you wouldn't be able to continue it. And you're right, that would be, depending on how long the person was there, could be pretty concerning. From a clinical perspective, there's actually been some studies that have suggested that because we don't know what hormones do, and this is not just gender affirming hormone therapy, but also menopausal therapy, contraception, though there's been more research on those. It's tempting, using the words from the paper, tempting to attribute whatever's wrong with the person to their gender affirming hormone therapy. So in the case of Dr. Whitley that I showed earlier, he presented with kidney failure, and his physicians immediately said, oh, it's because you're on testosterone, which when you look at what the actual diet cause of his kidney disease was, they have nothing to do with, so they told them to stop it, which, I mean, that's huge. He'd been on it for 20 years. Yeah. So I don't have a great answer to your question, but it's a good one. I don't know if other people have comments too.
Yeah, it's just something we're trying to factor, as we're submitting grants and looking at different interventional therapies, these are things we need to take into consideration for the patients that are coming in and what their baseline is.
Well, if I may say that, it's a great question. I think hormones are often considered not required, treatment. And I think that if someone is in coma in an ICU, it's possible that the hormones can be stopped. And so certainly highlighting the importance of continuing the hormones is one thing. And in terms of the effect that having stopped the hormones may have on recovery, I just want to tell you about an article I read in the New England Journal about a transgender person who wanted to conceive a child and had to stop, the male modifying drugs, hormones. And then because of that, became so depressed because of the, change, in terms of the sexual, changes. So I'm sure that if that happened to someone who had brain injury, and then on top of that, there were some changes that are related to not taking the hormone. So, they would affect the person's mental state for sure. So it's, it's a very important question, and it's very important to continue these medications during recovery, because you don't want the person on top of everything else to be, to develop depression because of the lack of hormones.
One of the things that I've always thought was quite strange in medicine, not being a doctor, is that what we refer to as sex hormones are really steroid hormones.
Mhm.
And they're steroid hormones just like cortisol and prednisone. And you would never take a person off prednisone cold turkey. You would always ramp them down. And yet I think of people being taken off estradiol therapy, androgen therapy without a lot of consideration that these might have exactly the same sorts of effects as, or, detrimental effects as taking somebody off prednisone quickly.
But just to say that the effect of withdrawing different hormones is different, so it would not have the same effect, but certainly has some effect, So you're right, they're not considered as seriously as steroids. You're right. Should be.
We should have clearly had another hour of discussion, but I'm wondering if we should move to the breakout rooms. Jill, do you think that's?
Sure. That might be good. People might enjoy talking with each other individually. Some of the shy people who haven't raised their hands, which is a lot, might like to talk in a breakout room. We could try that. So how will these breakout rooms work, Lisa? Will the different speakers be assigned to a different breakout room and you and I'll pop around?
Catherine, I hope is going to come on, or the
I'll just start the breakout rooms right now. Everyone will be able to self-select to the breakout room that they want to chat in. We'll have a couple of SGBA experts available in each breakout room. So feel free to discuss some of your questions, some of the resources that you've encountered over the years that have been helpful to you, and just have some general conversation. Lisa and Gillian here will pop into all of the breakout rooms at some point in time. We will be concluding at 1:30, bringing you all back into this room to say goodbye and to thank you all. So I'm just going to open that up now.
We told Greta, Sophia, Robert, Paul, or Louise, so they're off the hook. But if they want to go in a breakout room, they can. But so just before that, I think we've got to say thank you so much.
Yeah, thank you so much to the speakers. Really terrific, and it's like a brilliant choice of speakers because it's quite the gamut of approaches and views on gender. So that was really great.